Yeah, good morning. I am Dr. Emmanuel J from Ghana, and my presentation is on Mycobacterium ulcerans disease in the middle belt of Ghana. This is an 8-year review from 6 endemic districts. Can we go to the next slide, please? Next slide. Yeah, Mycobacterium ulcerans is an acid-fast bacillus growing at a temperature between 30 to 32 degrees Celsius and on Lewis-Johnson medium. It produces a microbiotronson toxin when infected with a plasmid, and the toxin is cytotoxic and immunosuppressive, causing extensive destruction of tissues, leading to large ulcers on the exposed parts of the body. Can we go to the next slide, please? Now, spontaneous healing of the ulcers can occur, but then it leads to contractures, subluxation of joints, tissue atrophy, and distal lymphedema. The disease is classified into the ulcerative forms and the non-ulcerative forms. The non-ulcerative form include the papule, nodule, plaque, and edematous lesions. The ulcer, which is referred to as Bururi ulcer, has undermined edges, is peripherally indurated, and the slough in the wound is like cotton wool, very white, and the lesion is generally painless unless it is secondary infected. Next slide. So the disease has been classified into 3 types. Category 1 is a single lesion which is less than 5 centimeters in diameter. And category 2 is a single lesion between 5 and 15 centimeters. Category 3 is a single lesion which is more than 15 centimeters in diameter, or multiple lesions, or lesions at critical sites, such as around the eyes, the ears, the nose, and so on, or when bone is infected, causing osteomyelitis. So these are pictures of early lesions. You call them the papule, and you can see them on the limbs of a child. This can easily be mistaken for insect bites, which is common in the tropics. Next slide. And the next stage is what is called the nodule, which is an indurated lesion which can actually be palpated and moved in the tissues. So next slide. So the next stage is the ulcer, and typically is found in children or in the lower limbs of adults. For example, in this picture, you can see on the left side, on the left cheek and orbital region, an ulcer with associated swelling, edematous swelling of the left half of the face. On the right picture, you can see ulcers on the neck and submental regions. So these are typical Bururi ulcers in children. Next slide. And it also affects their limbs, especially the upper limbs, and it can be very extensive, and it can be easily be mistaken for necrotizing fasciitis, which is also common in the tropics. Next slide. It can also affect the lower limbs, and it can cause contracture of the knee joint. And in the picture on the right, you can see a contracture from Bururi ulcer involving the ankle joint. Next slide. Sometimes the patient presents with complications already. For example, the picture on the left, the patient has treated himself with herbal preparations. And so when the wound healed, the limb, which actually the right upper limb, is deformed, as you can see. And sometimes there's another complication called the edematous lesion, where the whole limb is very swollen. But surprisingly, with this swelling, the child is very well. Whereas if this swelling were due to a pathogenic infection like streptococcal infection or staphylococcal infection, cellulitis, the child will be very ill. So despite the huge swelling and the ulceration, this child is perfectly well and may be playing around. Next slide. So epidemiology, the disease occurs in tropical and subtropical areas. It's found near water bodies, rivers, lakes, marshy areas. The exact mode of transmission is not known. In Ghana, the disease has been reported in all the regions of the country from a study done in 1999. Next slide. Next slide. Yes. So a background. Ghana is located on the west coast of Africa, and it is bounded on the north by Burkina Faso, on the west by Cote d'Ivoire, on the east by Republic of Togo, and the south is by the Gulf of Guinea, like the Atlantic Ocean. The vegetation of the northern part of Ghana is savanna. In the middle belt is rainforest, and the coastal belt is thicket interspersed with savanna. The population of Ghana now is about 30 million. Accra is the capital and is located on the east coast, and Kumasi is the second largest city in the middle belt. And it is around this area that we have a high incidence of the disease. The major occupation of the people in the middle belt is farming. Next slide. So this is a map of Ghana. And as I said, you can see Burkina Faso, the northern border, Cote d'Ivoire on the west, and Togo on the right. So that's Accra, and this is Kumasi, where the disease is endemic. On the map of Africa, Ghana is located on the west coast, as shown here. Next slide. So the World Health Organization has recommendations for the management of Burul ulcer disease or Microbiotronson disease. Normally, the recommendation was to start with antibiotics, and the antibiotics that are recommended are rifampicin and tetomycin or amikacin, and you give that for 8 weeks for all forms of the active disease. When you do that, smaller lesions like the nodules that we saw can be treated on outpatient basis without hospitalization. Surgery is required to remove necrotic tissue, cover skin defects, and correct deformities. Then we institute interventions to minimize or prevent disabilities, mainly physiotherapy for the movement of limbs which have been affected by contractures. Next slide. So the study was to document the clinical and epidemiological features of Microbiotronson disease in the middle belt of Ghana and to document the outcome of treatment. The study design was retrospective from 2005 to 2012, and the setting was districts in Ghana are Afano, Amansia Central, Amansia West, Esunafo, Esotifi, and Upper Denchira. All are districts in Ghana. Next slide. Next. So the patients and methods. The patients with suspected Microbiotronson disease were screened by community workers, and the diagnosis was confirmed by a direct smear examination for acid-fast bacilli. Then you can also do a culture on Lewis-Janssen medium. Some of the diseases were also confirmed by histopathology of tissue excised at surgery, or you can also do polymerase chain reaction from the Kumasi Center for Collaborative Research into Tropical Diseases. So when the disease is confirmed, then they are treated with intramuscular streptomycin, about 15 milligrams per kilogram of body weight, and then oral rifampicin, about 10 milligrams per kilogram body weight. And that combination is given for 8 weeks. Next slide. So surgery is indicated for those patients whose lesions have not healed after medical treatment, or those in whom medical treatment had failed, or those in whom medical treatment is contraindicated. For example, pregnant women and some children, and then those presenting with complications of the disease. So these are selected for surgery. Next slide. So to be included in the study, a diagnosis of Microbiotronson ulcer disease should have been made, and then the diagnosis confirmed. Then the diagnosis have been confirmed by any of the above tests. And then the person should have completed 8 weeks of rifampicin and streptomycin combination. Or the patient has undergone surgery for biliary ulcer disease. So these are the inclusion criteria for the study. Next. So the results. 518 patients were seen in the districts, in the endemic district from the period 2005 to 2012. 260 patients were treated solely with the antibiotics, that is rifampicin and streptomycin combination, and their lesions healed completely. But 258 patients either had antibiotics and surgery or had surgery alone. Their ages ranged from 1 year to 3 months, 1 year, 3 months to 98 years. And the mean age of the patient was 29.8, standard deviation 20.4. The clinical forms that were found were the papule, the one we saw, about 0.7%, nodule, about 1.5%, chronic osteomyelitis, about 1.5%, contracture, about 1.5%, and then the edematous lesion is about 2.69%, and then the ulcer was the commonest, about 92% in this study. Then there were some complications which were not originally known by the disease. This includes subluxation of the knee joint from the disease in one case, and then salivary gland fistula, also one case, and then Magellane's ulcer, also one case. That is the disease becoming malignant. Next slide. So the distribution of the lesions on parts of the body are shown in this table. The head and neck had about 5.8%, upper limb about 23.2%, trunk 1. Oh. Next slide, please. Yes. Next. Oh, please go. All right, let's start from here. This is a picture. Back one slide, please. Go back one slide. So the surgical procedures that were performed for the patients included skin grafting, about 66.2%, wound excision alone, 7.7%, skin grafting, 6. Was 6.2%. Then the release of contracture was 4.6%. Regrafting of a failed graft, they were 4.6%. And then the sequestrectomy, removal of dead bone, and then exploration and ligation of a fistula is also 1.5%. Next slide. So this picture shows the efficacy of the antibiotic treatment. This boy was about 9 years. He had Bururi ulcer of the left cheek. You can see the whitish exudate here. That was the time he was diagnosed. And then 2 weeks after treatment with rifampicin and streptomycin alone, you see that the slough has separated and the edema has subsided. Next slide. Next. Next slide. No, back one slide. Yes, thank you. So 4 weeks after the antibiotic treatment, you can see that the wound is granulating on the left picture. By 8 weeks, the lesion has completely healed, as you can see on the right picture. Yes, so this patient was also seen with a complicated disease, Bururi ulcer. And so we had a contracture on the dorsum of the hand, and we have to do surgery to excise the contracture and straighten the hand. So that the before and after the release. Next slide. So after the scar, the contracture has been excised, then we use a flap, the groin flap, to cover the wound, as you can see on the right. It was taken from the groin and it was sutured into the defect, as you can see on the right. Next. And then there's also a complication we met in the field. A child with a Bururi ulcer of the left cheek, and he was losing a lot of saliva through the wound, which means the disease had actually affected the salivary gland. So we had to explore, find a fistula, and ligate it. And so that was before and after the exploration and ligation of the fistula. Next. Next. Yeah, so the discussion. You can see from the tables that the earlier forms of the disease, the papule and the nodule, are very rare, small percentages. And why is this so? Probably the antibiotics are very effective, and so they easily deal with those. So they are not very many when you go out looking for them. Or the lesions are also painless, and the nodules and the plaque, they are not deforming. So busy farmers will not get time to report such small lesions to the field workers. And sometimes too, it is due to the inexperience of the field workers to detect these early lesions. But it is very clear that early institution of antibiotic treatment reduces the extent and sometimes the need for surgical treatment. And the combination of antibiotics and surgery provides optimal results and prevents the development of complications like contractures. So surgery may be the only treatment for some of the complications of the disease, especially those that are managed by traditional healers, the herbalists. When the wound heals, then they will get the complications. So in conclusion, early case detection and institution of medical treatment may obviate the need for surgery in mycobacterial ulcerous disease. And for advanced disease and its complications, surgery and physical therapy will provide the optimal results. Thank you for your attention.